party.
Anyway, thank you, Anuradha, and congratulations.
Sir, good morning, sir. Sir, good morning all, sir. Thank you so much.
పార్టీ ఇవ్వాలి.
సార్ తప్పకుండా అన్న సార్, ప్రాక్టికల్ అయిపోతే అసలు వద్దన్న పార్టీ ఇచ్చేస్తాను సార్.
డబుల్ పార్టీ అమ్మా.
ఎస్ సార్, థ్యాంక్ యూ సార్.
Many happy returns of the Omkar.
One more thing also is Dr. Pratyusha ఉన్నారు కదా సార్, మన దగ్గర ఐడి సిస్టమ్ చేశారు, అదే she also has passed.
Okay. Congratulations.
Congratulations to Pratyusha and happy birthday to Omkar.
Congratulations, Pratyusha, and happy birthday, Omkar.
So next class will be Anuradha.
Congratulations, Anuradha and Pratyusha.
Thank you, ma'am.
Good morning, all of you. Today is a special day for Anuradha and Pratyusha. Congratulations, both of you.
Okay, అది కాదు ఆ పైది ఇక్కడ ఇటు పక్క ఇందులో పై.
హలో
David, start చేయండి. David,
వినిపిస్తుందా?
వినిపిస్తుంది.
Congratulations to Anuradha and Pratyusha. And today Dr. Satish is going to talk on acute meningitis and encephalitis in ICU. Anna?
So by the slide, I remember Satish spelling is different and important.
Yeah, I also typed the same spelling. Anuradha spelling also is different. Anna, please start. Hello? Hello?
Satish, start చేయండి.
Good morning all.
Please continue.
Yeah. So, అయ్యో ఎందుకని. Yes. Yeah. Today's my topic is acute meningitis and encephalitis management in ICU. Meningitis, my topic will go through these following headings like definition, presentation and clinical features, early management and evaluation, epidemiology, investigations, treatment, complications, long-term care, sequelae and prognosis. So coming to the basics anatomical aspects, so we all know what is meninges, what is encephalon. So meninges are the like coverings of the brain, and the space between these meningitis we call them as like spaces like extradural space, subdural space, subarachnoid space. So looking in this picture, we can say that there is dura and this pia mater. These two are the areas where we found the infection. So we call it as inflammation of these meninges, and because of the infection, it is meningitis. When it goes to the brain parenchyma, we usually call it as encephalitis. So there are two entities now we are coming across like meningitis, encephalitis, and there is an overlap syndrome called as meningoencephalitis. So introduction to my topic, it's an inflammation of the meninges and is called as meningitis, and inflammation of the brain parenchyma is encephalitis. It's a neurological emergency and very difficult to distinguish between the meningitis and the encephalitis. So hence we are bound to start an empirical both covering the meningitis and encephalitis issues. Like usually meningitis is caused by bacterial infection and encephalitis is caused by viral infection. So in the G-rover, better to start both bacterial and viral coverage. And the key point in this identifying and diagnosing meningitis or encephalitis is the CSF analysis, and there is no shortcut for this. And presentations, maybe it's a slow onset. Sometimes we might get carried away, but like some encephalopathy, like hepatic encephalopathy, uremic encephalopathy, drug-induced encephalopathy, something like septic encephalopathy. So we need to identify whether it is real disease that is pertained to the meninges or brain parenchyma, or it is a remotely happening because of the reactionary issues. Like, so we need to identify these two things, like it's an encephalopathy or meningitis or encephalitis. So the characteristic findings of these infections are like patient usually have fever and there is an altered sensorium and plus or minus CNS symptoms like seizures. So if these things are there, like we need to have a suspicion. Sometimes some patients are presented with fever with headache and vomiting. So all these things need to have a wide spectrum of open-ended anticipation that these patients might have meningoencephalitis or meningitis. Diagnosis always is like CSF analysis should be done. And that's a very, very important thing. We need to look into various parameters of the CSF like biochemistry and the CSF blood counts, CSF cultures. So these things are important. Then bacterial and viral meningitis also we need to the differentiation factor happens only through the identification of the organism in the CSF, or which aids maybe blood cultures can aid to this diagnosis. And bacterial meningitis, that's what symptoms of meningism with appropriate blood culture is seen. Rapid diagnosis and treatment of acute meningoencephalitis with antibiotics or antiviral therapy is the key factor, because if we miss the viral meningitis in the early days, maybe there is no point expecting a reversal of the patient if it is like delayed treatment in the viral perspective. So the overlap syndromes, like when do we call it as meningitis, when do we call it as encephalitis, is there anything like there is a clear-cut delineation, demarcation line? So it's very difficult. Presence of an absence of the brain functions. If the most of the meningitis symptoms, like there is less occurrence of the as per the CNS symptoms. Like if it is encephalitis, we'll be coming across more of the CNS symptoms like focal neurological deficit, seizures, and a drop in the GCS. These things are there. In meningitis, in encephalitis, whereas in meningitis, it is only cerebral irritation will be there. Patient presents with headache, neck stiffness, like altered sensorium, but they're usually seizures and focal deficits may not be there in as per the isolated meningitis. But sometimes seizures and post-ictal state get confused with meningitis and encephalitis. And the commonest neurological manifestations in encephalitis is hemiparesis, flaccid paralysis, and paresthesia. So there is no clear-cut line to differentiate this is meningitis and this is encephalitis. So better to start empirical combination therapy, which covers both meningitis and encephalitis. Epidemiological factors, like what are the causative organisms commonly we come across? That's bacterial origin. And in Indian conditions, we need to suspect that tuberculous meningitis is one of the entity. Viral meningitis, fungal meningitis in immunocompromised patients. Aseptic meningitis, where there is culture CSF is not suggesting of any bacteria or any virus or fungus. And there is another entity called drug-induced meningitis. In the community-acquired meningitis, bacterial meningitis, the common organisms are streptococcal pneumonia, Listeria meningitis, and Haemophilus influenza. And in the Southeast Asian countries, like our Indian countries, we need to suspect even Streptococcus suis also. And Listeria monocytogenes in the extreme age groups, like higher age group, more than 50 years or less than 1 year pregnancy. These people, we need to suspect Listeria monocytogenes. Group B Streptococci. Gram-negative bacteria can also identify one of the culprit for this meningitis. Example is E. coli and Klebsiella pneumonia. Risk factors for Listeria meningitis includes immunocompromised patient and a chronic illness, patient who is having diabetes, alcohol dependency, malignancy, old age, pregnancy. Among the viruses, enterovirus is the commonest. Next comes the herpes simplex. And Indian scenario, in the poor socioeconomic status, that background, we need to suspect Mycobacterium tuberculosis. Fungal infections like typical Cryptococcus in immunocompromised patients. Nosocomial meningitis, particularly patient who underwent a LP or something for a anesthesia purpose or from something. Second thing is patient is having a neurosurgery or patient is having a CNS trauma. So we need to understand that catheter-related CNS infections. And more so it is Pseudomonas Klebsiella when it comes to the gram-negative organisms. When it comes to the gram-positive organisms, it is MRSA again. So shunt-related infections, we need to look into Streptococcus, Staph epidermidis, Staph aureus, Enterobacteriaceae, and Pseudomonas. And we all know that Acinetobacter is the commonest indwelling pathogen in the tertiary care ICUs. So that is also in the list. Sometimes we need to look into the there is possibility of parasitic infections causing meningitis, like Toxoplasma gondii and some amoebic encephalitis. Comes to the viral, encephalitis mostly in enterovirus like Coxsackie and Echovirus. Next comes herpes simplex. And the treatment of choice for this is acyclovir. Other viral infections, we don't have any specific treatment, but if we suspect that it is herpes, maybe acyclovir works in these patients. Less common causes include mumps, HIV, cytomegalovirus, varicella zoster, and Epstein-Barr virus, human herpes virus are increasing in immunocompromised patient because of background of any HIV infection. We need to look. Fungal infections, again, it is secondary to systemic mycosis, and Cryptococcus species in immunocompromised patient. Candida infection is an ongoing systemic infection. There is no isolated candida in the brain, but patient who is having a candida bloodstream infection, there is a possibility patient may get a candida meningitis. Aseptic meningitis is an entity where we are not able to find out any organism. Patient is clinically suspected to have a meningitis, but and laboratory evidence like CSF protein is elevated, sugar is reduced, but still we are not able to find any organism in the cultures or in the CSF. We call it as aseptic meningitis, and most common entity is enterovirus. And additional etiologies like mycobacterium, fungus, and spirochetes, and parameningeal infections, paraneoplastic presentations also present as aseptic meningitis, and sometimes medications that causes meningitis. In my next slide, I will discuss about those medications. Many patients with aseptic meningitis, particularly we find that if you really find out, there will be a virus origin will be there in the background. So drug-induced meningitis is basically it is a drug reaction or idiosyncratic reactions to the drugs. Commonest are NSAIDs and trimethoprim sulfamethoxazole, intravenous immunoglobulins, and rifaximin and cetuximab, anti-epileptic drugs. The mechanisms are either delayed hypersensitive type reaction or direct meningeal irritation. And the CSF analysis typically shows is neutrophilic pleocytosis. And this is a self-limiting disease. Mortality is very, very less in these conditions. Coming to the presentation, how those patients are presented, what are the clinical characteristics of community-acquired bacterial meningitis and what is the diagnostic accuracy? So we have found that the triad like headache, fever, and nuchal rigidity is very particularly in the meningeal inflammation, that is meningitis. Whereas if it is a problem with the encephalitis like brain parenchymal issue, we find that patient will have more of symptoms of related to the CNS like focal neurological deficit, seizures, aphasia, hemiparesis. The classical triad only seen in less than 50% of the patient, that is fever, stiffness, and altered sensorium. And 95% of the patients who have 2 or more symptoms, most of the times all the 3 may not be there, but at least 2 will be there in 95% of the patients. Out of these 3, 2 combination will be there. Either patient may have a headache and fever, or a fever and neck stiffness, or a headache and neck stiffness. Any 2 of these 3 symptoms we can find, and this probability is up to 95%. And seizures are due to cortical irritation, and it's an independent risk factors for the mortality in these patients. And particularly in the patient who is having multiple cerebral infarct secondary to vasculitis or venous thrombosis, may cause cerebral edema and raised ICP. We need to understand raised ICP is one of the concern when we subject the patient for a LP, CSF analysis. Rash associated with these 3 findings is identified in 20 to 50% of the patients, and most of the meningococcal meningitis patient will have 90% of the patient will show petechial rashes. Neck stiffness, we can see in the 31% of the patient, Kernick sign, 9% of the patient, Brudzinski sign, and 11% of the patient. Very low diagnostic accuracy. Most of the patient may not have these signs. Ataxia and labyrinthitis is because of the influenza meningitis. Cough, weight loss, and cranial nerve involvement, maybe it's like a leading point to suspect there is a tuberculous meningitis. Septic shock, pneumonia, disseminated IVs, intravascular coagulation, maybe is a worsening of the complications of the bacterial meningitis. So nuchal rigidity, we come across 2 signs, Brudzinski sign and Kernick sign. Both signs are pointing towards meningeal irritation. Kernick signs is that when there is a resistance to the extension of the leg while the hip is flexed. So this is when the hip is flexed here 90 degrees. When we try to extend the knee joint straight away.
మధ్యలో వాయిస్ ఏదో కట్ అవుతుంది, కొంచెం స్లో చెప్పాలేమో, మధ్యలో వాయిస్ డిస్కనెక్ట్ అవుతుంది.
Sorry, sir. Sorry. So resistance to extension of the knee joint when the hip is flexed and the patient is lying flat, it is Kernick sign. Brudzinski sign is when the patient is trying to flex his neck forcibly, there will be flexion of the knee joint. These are the 2 signs related to the nuchal rigidity. Then the clinical presentation, the viral meningitis, particularly is a prodrome of fever, headache, myalgia, and mild respiratory infections. Altered mental status and focal neurological deficits are seen associated with seizures. Patient may have a herpetic rash because if it is like herpes simplex in encephalitis. Brainstem involvement, diplopia, dysarthria, and ataxia may be present in immunocompromised patients. Personality changes, memory loss, confusion, olfactory, when there is an involvement of the temporal lobe or orbitofrontal lobes, particularly in the herpes simplex encephalitis. So what are the diagnostic accuracy of the looking at the algorithmic approach? Is there any specific pointing diagnostic criteria that we can look into the algorithmic approaches? No. Definitely none of the published diagnostic algorithms are 100% sensitive upon validation of the independent cohort indicating the bacterial meningitis versus viral meningitis, looking at the algorithmic approaches. Like so, none of these algorithms that are available as of now does not have any specific identification, help us in specific identification between bacterial and viral meningitis. However, these are they aid to the diagnosis, but even though they are not very specific, but there is high possibility to delineate between the acute bacterial meningitis, and the clinical judgment is key when considering whether to start empirical antibiotic along with empirical antiviral and adjuvant therapies. Coming to the lumbar puncture and the CSF analysis. So normally we look into opening pressures, TLC, differential count, sugar, protein, gram stain and cultures, lactate, PCR based assays, adenosine deaminase, mycobacterium tuberculosis, PCR and nucleic acid amplification tests. So looking at the leukocyte count, meningitis is confirmed when the leukocyte count exceeds more than 5 cells, and a leukocyte count is more than 1000 cells with a neutrophilic predominance is bacterial meningitis. Exception to this is Listeria monocytogenes, where there will not be predominantly increase in the leukocyte count. There is an increase more than 5 cells, but not to the point of 1000 cells. And it is more of predominantly lymphocytic, not, though it is a bacterial, it is not leukocytic, it is lymphocytic predominant, and cell count is not mounting beyond 1000. And less than 1000 cells with a lymphocyte predominant also seen in certain viral infections, tuberculosis and cryptococcal meningitis. Sometimes we find a traumatic tap. So in that conditions, we need to reduce the leukocyte count as per this formula. Leukocyte count should be corrected by detecting 1 leukocyte for every 500 to 1000 RBC in CSF. Protein wise, CSF protein is usually elevated in meningitis, both bacterial and viral, because of the increased permeability of the blood-brain barrier to this, because of the inflammation. So elevation is typically greater in bacterial and significantly very high in TB meningitis, and in viral meningitis, protein count is not that much elevated. Exceptions, again, meningitis due to herpes simplex viruses, there is a possibility of elevation more than 1 gram. And leukocyte count, CSF protein also, there is a correction factor when there is a traumatic tap. CSF protein should be corrected for a traumatic tap by reducing 0.01 grams per liter for every 1000 RBC. So these needs, one thing is when there is a traumatic tap, we have to correct the WBC count, we need to correct the protein count. Sorry, protein value. So coming to the glucose, low CSF glucose, we call it as hypoglycemia. The sugars are low in bacterial meningitis, also typically low in TB meningitis. Usually we look into the blood sugar versus CSF sugar values. There is a ratio usually maintained around 0.6. If it is less than 0.5, there is a significance. If it is more than 1 or equal to 1, there is another, like it's also significant. So the ratio is significantly less, like less than 0.23. It is more specific and specificity is very strong. When the ratio is just less than 0.5, the sensitivity is relatively more towards the bacterial meningitis, and specificity is very less, up to around 50%. So CSF glucose versus blood sugar levels, we need to look into this ratio. Normally it is maintained when there is no meningitis, it is 0.6. If it is less than 0.6, we need to have a suspicion that patient is having a meningitis. But how specific it is around 0.5, it is less specific. If it is less than 0.23, it is more specific of bacterial meningitis. So this is a overall nutshell of CSF analysis in the bacterial, viral, tuberculosis and fungal. coming to the lumbar puncture contraindications, before electively collecting CSF, the presence of clinical features for the CSF pressure sign must. So we need to understand that raised ICP is one of the contraindications for conducting an LP. So either we can look into the clinical aspects of the patient, looking at the signs that there is having a raised ICP, or we need to subject this patient for a CT prior to doing a LP. So clinical evidence, when there is a raised ICP, like first thing is look at for the any focal neurological deficit and any seizure, vigilant disorders, history of immunocompromised patient. So when these are the clinical signs are present, so these patients should be subjected for CT prior to the LP. So when there is clinical signs are absent, there is no need of subjecting this patient for a CT. So second thing is when there is a problem with the coagulation abnormalities. When the patient platelet count is less than 50,000, it's a relative contraindication to an LP, and INR is more than 1.8, and when there is a raised APTT more than 2 times, these are the relative contraindications. Better to correct this prior doing an LP. So what is the significance of clinical parameters to exclude a CT prior to the lumbar puncture? So focal neurological deficit, new onset of seizures, altered mental status, GCS less than 10 or less than 8, and any immunocompromised patient, these patients, we looking at this clinical aspects, definitely these patients require a CT prior to LP. The evidence-wise, CSF findings. CSF lactate concentration has a good sensitivity and specificity for differentiating bacterial from aseptic meningitis. So normal, the value up to 26 is the cutoff point. Usually we go with the blood lactate is more than 2, more than 4, then sepsis we look into. If it is more than 4, considerably it is like hypoperfusion state is getting established. But in the CSF lactate, the levels cutoff is up to 26 is the cutoff. If it is beyond 26, we need to suspect that there is increased metabolism in the brain and increased glycolytic pathway is converting towards the lactate metabolism, and lactate is getting increased in meningitis. CSF cultures positivity up to 60 to 90% in bacterial meningitis, and it's a level 2 evidence. And CSF gram stain has an excellent specificity and varying sensitivity. Otherwise, all these 6 parameters are level 2 evidences, like negative CSF culture and CSF gram stain PCR as an additive value. When the patient time factor is the issue, we need to subject the CSF for rapid testing like PCR testing. In the absence, because we need to wait for the cultures to come back. Gram stain sometimes might be showing a mixed growth or no growth. So better to subject those patients to have a rapid PCR diagnostic testings. And the agglutination tests have less value, and it's unclear whether immunochromatography antigen testing has an incremental value. So that's all. These last two are the negative statements, and that is level 2 evidence. Otherwise, the first 4 statements like CSF lactate, CSF culture, CSF gram stain, PCR test have a positivity towards the diagnosis, and it is a level 2 evidence. Recommendations is patients with suspected bacterial meningitis strongly recommended to CSF leukocyte count. We need to look into protein should be seen, glucose concentration, perform CSF cultures and gram stain. It's a level 1 evidence like grade A evidence. And PCR based test is when there is CSF cultures are not contributory and we want a rapid diagnosis, better to go with a PCR based testing. And bacterial meningitis is suspected, it's strongly recommended to send the blood cultures and CSF cultures. And it is prior to the giving antibiotic. But do not waste the time in giving antibiotic just for the sake of waiting for the CSF analysis. So CTB for LP we discussed. Antibiotics wise, if lumbar puncture is delayed, should we start treatment? Yes, grade A evidence, start antibiotic therapy as soon as possible in acute bacterial meningitis. And do not wait for a CT or do not wait for a lumbar puncture before starting. Like if there is a possibility, like it's getting late, like CSF analysis is some reason we are not able to do. If the CT is not available, don't wait these starting antibiotic. Start antibiotic, don't worry. And then we can subject this patient for a CT or LP. But preferably, if there is a possibility, do CT or do an LP, then give antibiotic. So differential diagnosis of tropical infections, febrile encephalopathy patients who are having cerebral meningitis, so the cerebral malaria, dengue encephalopathy, leptospirosis, scrub typhus, septic encephalopathy, metabolic encephalopathies. Recommendations for empirical antibiotic, what antibiotic should be given. So we normally dwell with the patients between 2 years to 50 years or above 50 years. In the first two parts is pediatric patients. So any patient who is between 2 to 50 years, the most common organisms is Listeria meningitis and streptococcal pneumoniae. So vancomycin plus third generation cephalosporins are the recommended. If more than 50 years, in addition to this vancomycin and third generation cephalosporins, add ampicillin to cover the Listeria monocytosis. So medications. Does the addition of vancomycin or rifamycin to third generation cephalosporin improves the outcome? Yes. Ceftriaxone combined with either vanc or rifamycin result in high rate of CSF clearance, but does not show any advantage to the mortality benefit. So, but CSF is early clearance within 24 hours. CSF is completely devoid of the bacteria when compared to the monotherapy with the ceftriaxone. The treatment duration should be up to 10 to 14 days. So specific culture positivity, we all know what is the, if the culture is showing Pseudomonas, what antibiotic should be given. If the culture is showing MRSA, what antibiotic should be given. We all know that. I'm not dwelling here. But ultimately, most of the therapy of antibiotics is up to 14 days. Most of the culture positive things, we need to continue the antibiotic up to 14 days. What is the optimal type, duration, and method of administration of antibiotics? So evidence-wise, the recommended empirical treatment for bacterial meningitis is based on age and local resistance pattern. Then is susceptibility pattern should be obtained. And once it is obtained, we need to continue the antibiotic for 2 weeks. Surprisingly, sometimes we don't get any bacteria in the CSF or blood cultures. So what to do? We have already started empirical antibiotic, but cultures did not show any particular bug. So what to do? Continue the treatment for 2 weeks. A minimum of 2 weeks of treatment should be continued, irrespective of the patient recovery or not. So de-escalation is only done after 2 weeks. And the committee does not recommend the short course of antibiotics in a bacterial meningitis. And there is no like specific things how the way to be given. Should we give it as a ball or should we give it as continuous infusions? There is no specific recommendation. We give higher doses because most of the antibiotics require should cross the blood-brain barrier. So increase the doses and maintain up to 2 weeks it should be given. Particularly coming to the viral infections, if there is a suspicion of herpes simplex, intravenous acyclovir 10 milligrams per kg administered every 8 hours. And we need to keep it in mind that it's an nephrotoxic drugs. Serial follow-up of serum creatinine should be done and urine output. And total duration of treatment up to 10 to 14 days. There is an advantage, acyclovir can be switched over to oral agent. Coming to the steroids. So steroids, why the steroids are prescribed in this meningitis to particularly about the inflammatory effect of the antibiotics because of the cytokine release of the bacterial lysis. So most of the times it's an exaggerated response because of the release of the cytokine mediators, inflammatory mediators because of this bacterial lysis. And this particularly leads to seizures, sensorineural hearing loss, venous infarcts, and raised ICP. So treatment with steroids seems to be lower this incidence. So we need to start steroids along with the first dose of antibiotics. Current guidelines says dexamethasone 10 milligrams IV 6th hourly and concurrently with the antibiotic. So in pneumococcal meningitis, the duration of the steroids up to 4 days. And if we suspicion is not towards the meningococcal, if there is a possibility of viral or listeria, no need of adding pseudomonas, no need of adding steroids. Steroids are also recommended as a part of the standard therapy in TB meningitis. And specifically, it showed there is a reduced mortality. And the dose of steroids in TB meningitis is 0.4 milligrams per kg IV. And it's continued for 4 weeks and should be tapered over 2 to 4 weeks. In viral meningitis, early there is no role of steroids, which worsens the condition. But when there is a sequelae or complications are happening after the 4th day, there is a role of steroid in even viral meningitis. So should not be given in early phase there is an indication of steroid in late phase, that is after 4th day. Timings of the steroids, up to what point of time after starting of the antibiotic. So steroids are recommended along with the first dose of antibiotic, but we have given antibiotic, but still at what, up to what time the window of giving antibiotic. So it is up to 4 hours of start of the antibiotic, we can still start steroids. If it is beyond 4 hours of the start of the first antibiotic, there is no point in giving steroids. It's a level 3 evidence. Does dexamethasone have a beneficial effect on death, functional outcome, or hearing loss in the adult children? Yes. It has an advantage of reduction in the morbidity, but does not have any overall improvement in the mortality. So it reduces the hearing loss, it reduces the occurrence of the neurological sequelae, but did not reduce the overall mortality. So overall recommendations: empirical treatment with the dexamethasone strongly recommended in bacterial meningitis. Treatment with the dexamethasone is strongly recommended to initiate the first dose of antibiotic. If IV antibiotic treatment has already been started, we can start steroid up to 4 hours of the start of the first antibiotic. And it is recommended to stop dexamethasone if the organism found is not, it's like any other thing that is other than H. influenza and streptococcal pneumonia. So abruptly, we can stop the steroids. Coming to the complications: seizures, hydrocephalus, ischemic stroke, hemorrhagic stroke, subdural lymphoma, brain abscess, sinus thrombosis, hearing loss, hyponatremia like CSW or SADH. Neurological and systemic complications occur in large proportion of the patient. So when the MRI is required, when any patient is not improving after 3 to 4 days of treatment, these patients require a cranial imaging, and we need to chase out the symptoms. Like, don't wait for the complications occur. We need to proactively look into like MRI and CT and identify and repeat lumbar punctures, repeat the cultures. These are the level 2 evidence. Then bacterial meningitis complicated by hydrocephalus, subdural lymphoma, brain abscess may require a neurosurgical intervention. When to resort for a neurosurgical intervention? These are the indications, like when the patient is, there is a localizing abscess. So we need to, source control should be done. So there's a neurosurgical intervention is required. So all the investigations, follow-up investigation should be done in all these patients when there is no improvement even after 3 to 4 days of proper antibiotic therapy. And coming to the complications, like we come across acute hydrocephalus, in particularly in TB meningitis and cryptococcal meningitis, hyponatremia because of the SADH and cerebral salt wasting, seizures. 15% of the patient will get epileptic disorders in acute meningitis, hearing loss and the bacterial meningitis, particularly in the area of the cerebellum and posterior fossa, and stroke related to vasculitis, particular venous thrombosis, cerebral edema. These are all the complications. But we need to look into the raised ICP conditions, complicated meningoencephalitis. And when there is increased ICP and ventricular dilatations, we need to sort out for ventricular peritoneal shunts. These need things to be like considered. Glycerol, mannitol, and acetaminophen, paracetamol, these things like adjuvant therapies, how they are useful. So none of these have proven benefit in these patients. No particular specific, as long as there is no raised ICP, no role of mannitol, no role of hypothermia, definitely there is no role. So all these things are not necessary in treating these patients. Glycerol, no role; mannitol, no role; hypothermia, no role. And when do we resort for invasive cerebral perfusion pressure monitoring, like putting an indwelling catheter and measuring this? This is not useful in a patient with a normal meningitis. When the patient is landing up into the raised ICP complications, then there is a role of putting a indwelling catheter and measuring the pressures. Otherwise, there is no recommendation to measure the pressures inside the ICP. Measurement is not required. And adjuvant therapies like immunoglobulins, heparin, activated protein C is not recommended. Next is mortality wise. Whatever we do, 50% mortality is seen in these patients, and particularly in the meningococcal meningitis, 30% pneumococcal meningitis, 7% in meningococcal with sepsis. Morbidity is very common, and focal neurological deficits are seen in 50% of the patient. The commonest is hearing impairment, and 14% of the patients land up into the severe disability, neurological disabilities. So coming to the take home, it's a neurological emergency. Clinically, it is very difficult between a meningitis and encephalitis, particularly bacterial versus viral. Less than 50% of the patients show all the three of the components of the triad, like fever, stiffness, and altered sensorium. But 2 out of the 3 symptoms are seen in 95% of the patients. Symptoms are confirmed with the definite immediate CSF analysis, and consider a CT prior to the LP when the patient is having like raised ICP situations. Early broad spectrum antibiotics along with acyclovir saves the patient. Steroids along with the first dose of antibiotic or at least within 4 hours of the first dose of antibiotic is required, and close monitoring for the complications should be considered. Thank you, and it is open for discussion.
Thanks, Anna.
Thank you, sir. Thank you, sir. Satish, sir. We have a patient. Just 3 days back, one patient is admitted with us. The classic history of, sir, able to hear, no, sir?
Yes, sir.
The classic history of fever, headache, altered sensorium, and she came in shock. So we resuscitated the patient. After the resuscitation, we started with so our classic symptoms. We started with ceftriaxone, and we did not start on steroids. So little bit sensorium has improved. GCS was around 9 to 10 at the admission, and after fluid resuscitation, it has become 12. Then we have done imaging. Imaging is normal CT brain because there is a GCS is dropped. That's the reason why. Otherwise, as you mentioned, that if there is no neurological deficits, no need to do any of the imaging. Then the CSF has shown. So after that, next day after CSF, next day within 12 hours, patient improved well to 15/15 GCS, and the CSF was done after around 16 or 17 hours after antibiotic, and the protein is 75. GRBS is 270 at that time. It is 135 in the CSF, and cells are around 6. RBC is around 200. So, as mentioned in the textbooks, thousands I have never seen, sir, in the CSF, WBC, in a bacterial also, only except in 2 or 3 cases. So, what do you think, sir, this patient? So, we topped up with vancomycin and steroid, and again we stopped steroid. We have done ultrasound abdomen to rule out other causes. The other cause, the ultrasound abdomen is normal, and we are awaited for the cultures, urine culture, blood culture, and CSF culture. They sent for a TB PCR and HSV PCR. Sir, your take on this, sir?
So one thing is like there is some discrepancy where we are looking into the conversion factors. Like it is like liters. We normally do for a deciliter.
Yes.
So that is the confusion here. So the 1000 is, yes, it seems to be big figure, but it is for liter, it seems. Sure, sir.
Srinivas sir, just we had recently a patient admitted under us meningitis. His LP.
Sir, ఒకటి discuss చేద్దాము.
లేదు అది కాదు, మీరు అడిగిన క్వశ్చన్ కే చెప్తున్నా. The cell count is 25,000.
25,000?
25,000.
అది పస్సే ఉంటుంది సార్, ఇంకేముంటది అందులో?
95% lymphocytes.
95% or 96% lymphocytes ఉన్నాయి, and protein is 135. And we got 25,000 counts.
So is it any malignancy ఏమైనా ఉందా పేషెంట్స్ లో?
లేదు సార్, లేదు. Finally found out to be a tubercular meningitis.
Okay. Okay. So ఇప్పుడు ఈ పేషెంట్ ని ఎలా ట్రీట్ చేయాలి?
Sir, we are done after 16 hours. And it may not be a true value of what is that without giving an antibiotic. So it's a partially treated meningitis. So now entities wise, we can look into it's a partially treated meningitis. Patient got exposed to antibiotic prior to the LP, that is 16 hours after the antibiotic. So we don't have a classical picture of CSF analysis in such patients.
ఎందుకంటే సార్ ఒకటి why I asked this question is, if I am suspecting a urinary tract infection in this patient, because the classically
agent
sir
age
is around 50 to 60 మధ్యలో ఉంటుంది సార్, ఫీమేల్ పేషెంట్. అంతేనా రఘు? ఉన్నావా రఘు? రఘు ఉన్నాడా?
అంతే సార్. And 55 years uncontrolled sugar, sir.
Uncontrolled sugars. So,
8 to 10% in UTI, CU. That's why we suspected UTI.
It could be septic encephalopathy, no? Why it is meningitis?
అదే అనుకుంటున్నాను. See, it can be that also.
కదా ఎక్స్ట్రా ఒక సెల్లే కదా ఎక్స్ట్రా 6.
సెల్ ప్రిడామినెన్స్ ఏముంది?
న్యూట్రోఫిల్ ఉందా?
లింఫోసైట్స్ సార్,
లింఫోసైట్ ప్రిడామినెంట్.
లింఫోసైట్స్ ఉన్నప్పుడు we have to suspect. And TB-PCR గాని ADA గాని?
ADA నెగటివ్ సార్, 1 ఉంది ADA. TB-PCR పంపిస్తాం సార్, ఇంకా రాలేదు.
కానీ మోస్ట్లీ
TB-PCR అండ్ HSV-PCR పెండింగ్.
ఓకే సార్, కానీ ADA నెగటివ్ ఉంది, లింఫోసైట్ ప్రిడామినెంట్ ఉంది అన్నప్పుడు వైరల్ కి వెళ్ళే ఛాన్సెస్ ఉండొచ్చు.
So, e patient, as he is mentioned, David mentioned, it can also be a septic encephalopathy anante is also a possibility. Kani ikkada nenu antibiotics we have started on ceftriaxone and vancomycin and acyclovir kuda start chesinda neurologist?
Yes sir,
acyclovir kuda unnadi, 3 ఉన్నాయి. సో ఇప్పుడు ఈ పేషెంట్ కి ఒకవేళ నేను కనుక ఇది యూరినరీ ట్రాక్ట్ ఇన్ఫెక్షన్ అని అనుకుంటే కనుక, then none of these drugs works for her. But a septic shock resolved, because at least a BLI has to be there in this patient. అందుకనే జస్ట్ ఇది ఏది అనేది కానీ హిస్టరీ వైజ్ క్లాసిక్ హిస్టరీ, ఫీవర్, headache, altered sensorium, classic history.
And neck stiffness also
is there.
Okay, if you are really worrying about the urosepsis and septic encephalopathy, you have to cover urosepsis and you have to cover the antibiotics to cover the meningitis, and also you have to cover not BLI, we have to cover the ESBL, E. coli or Klebsiella, to cover both meningitis and urosepsis. Then what antibiotics you will choose, Anna?
Asking me?
Yeah, both of you, anybody.
In the same scenario, Srinivas sir, if there is a suspicion of some sepsis is happening, but there is a possibility of meningitis, but importance is given to the meningitis because it requires larger doses. So empirically, do a CSF, start high dose of BL-BLA combination or ESBL coverage. I would go with the meropenem 2 grams TAD, which covers the brain and which also covers BL-BLA or ESBLs. And rest of the treatments are continued. Once the CSF is showing something, we'll de-escalate things. Because if we simply looking at that it is a urinary tract infection and we miss the CNS infection, there is a possibility. So hit hard in the first hour, start 2 grams meropenem TAD. Whatever the rest of the things that should be added, like you can add, if the age is more than 50 years, I am not sure what is this age, add ampicillin if you to cover the Listeria, add acyclovir also, and treat it as UTI plus or minus CNS infection.
If patient have AKI, like creatinine is more than 2, decreased urine output, can we continue vancomycin and acyclovir?
So vancomycin is still doubtful. We may or may not be using, but we can go with the trough levels. After initial 24 hours, there is no problem, we can start with. Then look at the trough levels and maintain more than 15.
This patient has a 1.65 undi. creatinine, no? But still
Sir.
we started on vancomycin
Yes.
because gram-positive infections are also very common, and good penetration will be there for vancomycin. Only my question is, suppose if it is, she has come from a community, so if it is an ESBL organism where the patient has responded to the fluid resuscitation ankunte, why don't we go with the cefoperazone sulbactam in this patient where the inflamed higher dose of cefoperazone sulbactam, where the inflamed meninges will be this drug can penetrate into inflamed meninges. What do you think, sir? What is your opinion?
Yes,
Why
sir.
to hit with meropenem?
Yes, sir. That's cefoperazone. That's what I'm telling. When you are telling that it is something, see, when the patient is having altered sensorium in a background of sepsis, it's like a severe sepsis. So better to start with high-end urinary tract coverage antibiotic, which also covers the CNS infection, that is meropenem. So because subsulbactam may not, if the patient is having a recurrent UTI, maybe we are missing that in the history. The patient might be having a resistant MDR resistant bug. So we are missing the initial coverage.
Okay, sir.
Did you check the abdomen to look after pyelonephritis?
Ultrasound is normal, sir.
Okay.
Say we anyway
Muscles are 10 muscles are there.
So anyway we are going to de-escalate once the urinary cultures come back or blood cultures come back, and urinary we have to, because when time is there after 24 hours we can reascertain the patient whether the infection is pointing more towards the CNS or infection is more pointing towards urinary tract. But first our antibiotic only the discussion of point. So I would rather start meropenem and even further evaluate the patient.
What about why you de-escalated or discontinued steroid in this case?
Steroid, because if it is a urinary tract infection,
If it is meningitis, what you will do?
the patient has clinically responded well. అందుకనే నేను స్టాప్ చేశాను.
సార్ స్టెరాయిడ్ ఎన్ని రోజులు ఇచ్చారు?
వన్ డేనా రఘు? వన్ డే ఇచ్చామా?
ఒకటే డోస్ సార్, ఒకటే డోస్.
ఒక డోస్ అంతే.
After that patient is conscious and obeying.
ఆఫ్టర్ దట్ కాదు, ముందు నుంచే కూడా కొంచెం ఇంప్రూవ్ అయింది. ఫ్లూయిడ్ రిసస్పిరేషన్ చేయగానే
Then it could be, yeah, it could be a septic shock, urosepsis with septic encephalopathy.
అదే అదే కదా డౌట్. ఇప్పుడు ఇదా అదా అనేది కదా డౌట్.
Are coming same symptoms with fever, altered sensorium, along with.
సార్ అలాంటప్పుడే మన యాంటీబయాటిక్ హైయర్ యాంటీబయాటిక్ ఇచ్చుకోవచ్చు అంటున్నారు.
అందుకే మెరోపెనమే is the drug of choice in this case.
అంటే ఒకటి సార్, నేను మోస్ట్ ఆఫ్ ద టైమ్స్ వెన్ వి టేక్ ఏ హిస్టరీ, ఇఫ్ వి టేక్ ఎ వెరీ క్లియర్ హిస్టరీ, మనకు డయాగ్నోసిస్ 50-60% తెలిసిపోతుంది. ఇఫ్ యూ స్టార్ట్ ఆస్కింగ్ ద పేషెంట్ ఫ్యామిలీ మెంబర్స్, ఎందుకంటే ఈ క్లియర్ పిక్చర్ యాజ్ యూ మెన్షన్, సెప్సిస్ ఎన్కెఫలోపతి అయినా ఇట్లానే ఉండొచ్చు, అండ్ ఈ మెనింగో ఎన్కెఫలైటిస్ అయినా ఇట్లానే ఉండొచ్చు.
ఈవెన్ ట్రాపికల్ ఫీవర్స్.
మిగిలినది ట్రాపికల్ ఫీవర్స్. ఈ హిస్టరీలో ఏంటంటే వెరీ క్లియర్ హిస్టరీ సేయింగ్ దట్ ఇట్స్ ద పేషెంట్ ఈస్ హ్యావింగ్ ఫీవర్, హెడేక్, ఆల్టర్డ్ సెన్సోరియమ్. సో నో బర్నింగ్ ఆఫ్ మిక్చరేషన్ ఇట్లాంటివి ఏమి లేవు.
So we can call it as a tropical cocktail. We can go with the meropenem 2 grams BD, doxycycline and falcigo to cover the complicated cerebral malaria, and which covers leptospirosis and scrub typhus. All these things, 4 disorders like malaria, all tropical fevers, meningitis, even septic encephalopathy to be covered. No, this is the best way. I think a tropical antibiotic cocktail. Monosef 2 grams BD, doxy, falcigo, and acyclovir. First hour.
Patient came in shock,
Yes.
no?
Yes, sir. Okay, sir. We will. Next question, sir.
Mohan sir, please, what is your experience on this?
సార్ స్టూడెంట్స్ కి కొన్ని క్వశ్చన్స్ ఏమైనా అడిగితే
Please.
సార్.
అడగండి.
So already, as sir has said, Satish sir has said that you have to do a CT. In some cases, we have to do a mandatory CT. before an LP. So the scenario is if the patient is fully irritable and requires lots of sedation to get a CT done, and your patient is not cooperative for CT, and again you suspect some features of raised ICP because the patient is immunocompromised or some kind of seizure, and you want to do an LP. So what alternative can you do?
Sir, optic nerve sheath diameter.
Yes, Inka, right? Okay, you can see that.
Papilledema koda, sir, ophthalmoscopy.
Exactly. Yeah, you have to do a fundoscopy. Right? You are right. So what are the? There are some.
What about TCD?
Sir, TCD lo మీకు రాదు.
Oh, can we see that what is that systolic and diastolic?
Ra sir. And it is not a vascular issue కదా.
Vascular kadu for to check the raised ICP.
అంటే it is అంటే ఇప్పుడు దాకా అయితే it has not shown any significant changes in case of meningitis.
Yeah.
ONSD కూడా it is not a first thing that we have to do, but it is a fundoscopy that everyone expects, and second thing maybe ONSD.
Yeah.
But any first criteria is papillary fundoscopy. So sir has said about dexamethasone. So you have to give prior to the administration of antibiotic. So what are the disadvantages of giving dexamethasone?
Hello, Raghu.
Sir,
Sinju, Raghu, Tripti.
there can be chance of decreased CSS sensitivity, sir.
CSF sensitivity of what?
Cells TLC count can be decreased with
No. The steroid doesn't have any role with CSF leukocytes.
So metabolic complications, sir, hyperglycemia, electrolytes.
No, that will be already present, but that it is seen in every case. Huh? I am particularly asking about a case of meningitis or encephalitis. Sinju is there. Tripti is there. Mahesh. Okay, obviously your antibiotic penetration into the normal meningitis is very low. Once you are giving your steroid and your inflammatory response has decreased and your permeability of the antibiotic may decrease, and particularly in case of vancomycin you can have a very decreased penetration. And meropenem you are giving a higher dose because its penetration as compared to other BLVLAs, yes, there is definitely there. But if you see in meropenem particularly, you have to go for a higher dose in meningitis, even though it is permeable. In case your permeability has decreased, your 2 grams might not work properly also. In some cases, it is a very rare thing. Can someone name any other carbapenem which has CSF penetration?
Shall we give imipenem?
No, M. Recently it is
Sir, ఇవ్వచ్చు సార్. మీరే ఆన్సర్లు చెప్పితే పిల్లలు ఏం చెప్తారు సార్? Imipenem is the second choice of carbapenem.
And the newer one is also good, no? Its penetration is very good into the body fluids. Srinivas.
Why we don't give imipenem?
ఇప్పుడు అది క్వశ్చన్.
Seizure potential, sir. Seizure potential.
Why meropenem doesn't have seizure potential and imipenem have seizure potential?
Why imipenem produces seizure activity? Raghu.
మహేష్, సింజు అసలు నోరెప్పట్లేదు.
ఉందంట అసలు.
ఏం సార్? ఉంది. తృప్తి ఉంది, సింజు ఉంది, తృప్తి.
సరే చెప్పు శ్రీనివాస్.
Even it is wrong, someone has to express. అసలు ఎవరు ఎక్స్ప్రెస్ చేయట్లేదు.
ఇంకా తెలీదా రఘు?
శ్రావ్య, రఘు.
ఏంటి ఎవరు సై?
శ్రావ్య has some kind of answer. చెప్పమ్మా.
సార్ ఇమిపెనం పెనిట్రేషన్ మిరోపెనం కంటే ఎక్కువ ఉంటుంది సార్. సో లెవెల్స్
హలో
ఎక్కువ ఉంది సార్.
అది కాదు.
హలో,
వాట్ ఇమిపెనం కంటైన్స్ అమ్మా?
అంటే కాదు, మీరు
వాట్ ఇమిపెనం
ఎలా ఇస్తారు? వాట్ ఈస్ ద ప్రొడక్ట్?
ప్రొపిలిన్ గ్లైకోల్.
No. What imipenem contains another combination of another drug is there, no? With imipenem. What is that?
Cilastatin, sir.
Yes.
Yes, cilastatin has the seizure potential, not imipenem has.
Of cilastatin. Okay. Because imipenem cannot be stable without cilastatin.
Why it has to be given with cilastatin?
Dihydropeptidase in the renal, this excretion will be inhibited, sir. So more concentration is available.
Yes.
Srinivas. Hello.
So what are the routes by which meningitis can occur?
Sir, nasal, ear, from the ear infections it can spread.
Your voice cut out.
Sir, audible, sir? Hello?
Yes, audible.
Sir, from the sinusitis and meningitis, there can be local spread, sir. And particularly ethmoid and maxillary sinusitis.
Voice full ga break avutundi atla.
Okay.
Lele clear undi. Clear varu.
Raghu?
Sir, sinus and
ear infections, middle ear and inner ear infections. Then vascular penetration.
Okay, local surrounding structures. Okay, one route is by local surrounding structures. Another
is vascular, sir. Blood, through the blood from the from elsewhere, the infection will penetrate.
Hello? Shravya, నీ వాయిస్ మొత్తం బ్రేక్ అవుతుంది.
Sir, blood
నీకు నెట్ కష్టం ఉన్నట్టున్నది శ్రీనివాస్. ఇక మాకు బాగానే వినపడుతుంది.
నువ్వు చెప్పమ్మా. మీ ఇద్దరికి నెట్ ప్రాబ్లం అనుకుంటా. మాకు బాగానే అనిపిస్తుంది.
ఓకే, థ్యాంక్ యూ.
కంటిన్యూ అమ్మా.
Sir, local spread, ఇంకా blood penetration, sir. From the infection in pneumonia కానీ ఇంకెక్కడైనా వేరే ఇన్ఫెక్షన్ ఉంటే అది బ్లడ్ ద్వారా it will spread to the meninges. And then
any trauma to the blood brain barrier.
Yes, trauma.
And neuro hardware.
Okay, trauma. Okay.
And neurosurgical hardware.
Hardware అని చెప్పకూడదు.
Neurosurgical procedure.
ఏమ్మా?
Neurosurgical procedure.
అంటే ఇంకా catheters, sir. Catheters.
Indwelling catheters.
Indwelling catheters.
కదమ్మా, హార్డ్వేర్ ఎవరు వాడుతున్నారు?
Indwelling catheters అని చెప్పాలి.
Okay, sir.
So what is the most common?
ఎవరు వాడుతున్నారు catheters?
What are the most common organisms in case of what Sarah said about community acquired, right? So what are the organisms common in healthcare associated diseases?
Sir, H influenza, Listeria.
Sir, healthcare associated
healthcare.
Staph aureus, Pseudomonas, Acinetobacter, and then even the E. coli and other gram-negative organisms will be common, sir, in healthcare-associated pneumonia. Meningitis.
So, what is more common in healthcare? Which part is more involved?
So, which part, sir?
So which component it has? And suppose meningitis on the encephalitis on the some problems or other you unnai kada.
Encephalitis.
Meningitis is common.
అంటే హెల్త్ కేర్ దేని వల్ల వస్తుందని చెప్పు నీ హార్డ్వేర్ అదే indwelling catheters.
Indwelling catheters.
Okay.
ICD
So what will be more common? What will be more common?
EVDs and VP shunts.
అదే అంటే దాని వల్ల ఏం రావచ్చు?
Acinetobacter, sir. Pseudomonas and Acinetobacter.
Which component gets infected?
Staph or
which component gets infected?
Which organ?
meningitis.
See, meningitis, it's ventriculitis.
Ventriculitis.
Okay.
It's not meningitis, it's ventriculitis.
Catheter where they put, that is a source kada, akkada infection vastadi kada.
So first it is ventriculitis, then it will be spreading to meningitis or encephalitis, whatever it is, a distant spread. So what is the problem with ventriculitis?
Sir, hydrocephalus.
Blockage of
Yes, avenne unte already నీకు EVD ఉంది కదా.
Yes, sir. Adi a block అయిపోయి there can be drainage issues. So there
you can manipulate it from external side. No, what management issues that you get with ventriculitis? Okay. See, obviously, already as we have discussed, if your meninges are normal, your antibiotic penetration into the ventricles is low. Right? Even if you are meropenem or vancomycin, whatever you are speaking, it won't have very good penetration into the meninges or CSF. So you have to give an intrathecal doses. In a severe infection which is not responding, you have to give an intrathecal dose.
Okay.
Right?
Okay, sir.
So you have done an LP and the patient has not responded for 3 days. So what we will do? You have given some broad spectrum antibiotics and the patient has not responded.
Not responded in the sense, what is the meaning of not responder?
No, there is no clinical significant clinical response.
Sir, repeat CSF and look for other causes, sir.
No. What he asked, the patient.
No, ante sir, ante. నేను అడిగింది అంతే. You have to go for repeat LP. You have to repeat LP and other sources. So when will you repeat an LP? I mean to ask the what time? What time you will say that?
So beyond 48 hours, if there is no resolution in symptoms or neurological improvement, persistent and new onset deficits, then we have to go for a repeat CSF.
Okay.
Focal seizures.
Okay, if the patient has not responded for 48 hours, you are going to for a repeat LP. So are there any other cases where you do a repeat LP? What I'm talking about only meningitis and encephalitis and these things.
So viral ante inka resolution, even if you want to check for the resolution in the CSF or clearance in the CSF also, we can do a repeat CSF.
Yes.
Before that, again repeat chese mundu, better to do imaging again, at least a CT brain for this patient, because any anatomical changes unnaya leda chudaniki, and also we need to look into the EEG, ఏమన్నా subclinical seizures వస్తున్నాయో చూసుకోవాలి. Other things also we look into other metabolic abnormalities.
Okay, Anna. If no more questions, time is over. Thanks, Anna. Dr. Satish, for a very nice presentation covering both meningitis and meningitis. తప్పదన్న లాస్ట్ లో రికార్డు
సతీష్ గారు ఒక చిన్న డౌట్
చెప్పండి.
regarding our case scenario or Srinivas Jakina scenario, first we thought it could be severe sepsis, ఇంకా fluid resuscitation, antibiotics ఇవన్నీ స్టార్ట్ చేస్తాం కదా, and they needed a small dose of NORAD as well, all these. So we thought severe sepsis. అలా ఉన్న కేసెస్లో ఫస్ట్ డే స్టిరాయిడ్ ఇవ్వం కదా, we give antibiotic, send for all cultures and give antibiotic. But if you suspect meningitis, meningoencephalitis, you said first to give steroid even before giving antibiotic kada. In case if you think sepsis, but later you think it's not sepsis, it's mainly CNS infection, so can we give steroid bit later or don't give?
So that's now we are looking the problem from inside to outside. So we have a meningitis, all this discussion that it is something related to meningitis. You have a suspicion, but giving steroid is definitely a point of discussion. But if you really want to give steroids with the background of strongly suspicion of meningitis, steroid can be given up to the 4 hours of the start of the antibiotic. If still you have a suspicion that it is a possibility meningitis or sepsis, equally both the things can happen. Better to, it's an experience, there is no evidence for, better to withhold steroids because it is more pointing towards sepsis.
1 dose is okay, no?
That's what.
Sir, one dose lo ఏం చేంజ్ రాదు మీకు. At least it has to be given for 48 to 72 hours. Problem ఏంటంటే సార్, as madam,
No. Why I'm telling, if you give later after 4 hours of the antibiotic, no use of giving further doses.
In meningitis.
Adi sir, in
Yeah,
meningitis.
that's
So
why.
you don't know which
Continue.
kind of meningitis it is. So you
That's
don't
what.
know which kind of meningitis it is. If it is a tubercular meningitis, the patients will respond well to steroid even after you give, like after 3 days or 4 days, because the pathology is slightly different. So problem is we can't practically we don't withhold steroid.
కాదు శ్రీనివాస్, ఆల్ శ్రీనివాస్ and David, as madam is asking, is it more worse or beneficial? Because if it is dangerous,
No harm.
Yeah.
Because the
that's
dose
what-
you are giving, sir, the dose you are giving is not a immunosuppressive dose.
There is no harm.
we-
Benefit
we-
ఉంటుందో
sir, we
లేదో
Because
definitely గా
if
తెలియదు.
you
Sir, we
take
give,
the
Sir, we
Sir,
give
if you
24 milligrams per day
24 milligrams, yeah.
of Dexa, and a little higher dose only. And one more thing is, this steroids is not helpful for all types of infections.
Yes.
So only especially pneumococcal and tuberculosis and few other infections.
Yes.
So ప్రతి ఇన్ఫెక్షన్ కు పనిచేయదు. దట్ ఐ థింక్ క్లినికల్ గా డిసైడ్ చేసుకోవాలి.
లైన్ లో ఉన్నాడా? మోహన్ లైన్ లో ఉన్నాడా?
Mohan Rao.
Because there was one case, 23 years girl, Ishika, actually admitted and having a lot of CT scan without hypoxia, RT-PCR negative for 3 to 4 times, and admitted with Prem Kumar. Don't know what to do. No, she is comfortable. So only with the steroids she improved, surprisingly.
So that could be some vasculitis, sir. Vasculitis.
No,
Sir,
it's
it is a final thing is debate.
Some autoimmune disease, lupus. We have to rule out in vasculitis. We are unable to diagnose meningitis also.
Yeah.
He mentioned, no, Satish mentioned vasculitis and autoimmune diseases.
అంత క్యాచ్ లేకపోయాను,
Yes, sir.
అంత క్యాచ్ లేకపోయాము ఆయన క్లాస్ మొత్తం అంతా.
ఒక స్లైడ్ లో మెన్షన్ చేశారు డిఫరెన్షియల్ డయాగ్నోసిస్ లో.
Sir, the madam adding question ఏంటంటే ఫస్ట్ అవర్ లో ఇచ్చేటప్పుడు all this debate is only the first hour. టైం ఇస్తే మనం యూజువల్ గా we can pinpoint the diagnosis within 24 to 40 hours. Most of the times we'll arrive to a diagnosis.
Sir, మా కేసులో అయితే it took around 2 to 3 days.
అదే సార్, యూజువల్ గా 48 hours కి ఒక రీజన్ వచ్చేస్తుంది. మేబీ మనం we can come to a conclusion that we are really hitting what. So first hour steroids ఇవ్వడంలో తప్పు లేదు, first thing. Second thing is in the meantime we'll come to a conclusion. But even in sepsis and septic shock also, some people still go with the low dose of steroids, sepsis dose of steroids, it is indicated. So steroids does not have any increased risk to have a non-CNS infections or infections worsen అయ్యే కండిషన్ ఒక డోస్ తో ఉండదు. కాబట్టి ఫస్ట్ అవర్ లో ట్రీట్ ఇట్ as and hit hard with whatever that is possible, considering that it is meningitis.
Yes, otherwise the no use of continuous steroids. If it is meningitis, you will miss the boat.
Similarly,
Yes. Okay, Anna. Thanks, Anna. Thank you very much for
Thank you.
your presentation. Thank you all for your active participation. We'll close the session. Thank you.
Yes, sir. Thank you.
Thank you.